and does a tremendous job teaching dermatology within the department. She's a graduate of Indiana University School of Medicine, and then did training in dermatology at that place in Nashville, Vanderbilt, and has been here for about 5 years, and like I said, has been a tremendous asset to the department. And today we're going to talk about drug-induced dermatosis. Thank you very much, Dr. Hennings.
Thank you. So today we're talking about drug eruptions. So the objective is to differentiate between the different drug eruptions, identify the most likely drug causes for the eruptions, and learn the basic treatments of these conditions. So the first question whenever you evaluate a patient is, what does it look like? So dermatology has a lot of these words and descriptions to tell what a rash looks like. And they're important just for communication between physicians, and also to be able to figure out what the rash is. So you have your, when it's flat, if it's just red and flat, your macules and patches. When it's raised, it's more papules. And then if it's fluid-filled, it's a vesicle. And then if it's blood-filled, it's more purpura. And then if it's more pus-filled, it's a pustule. And then there's other words for different sizes. But why is that important? So if you really don't know what the drug is, you can go to what the rash is, you can go to visual diagnosis and plug in, it's adult, child, what it looks like. And here's where these words come into play. You need to know what it looks like, if it's flat, if it's raised, if it's pus-filled, if it's ecchymosis. And then you can put the distribution, and then it will pop up a differential for you. You have to be careful. You have to know, obviously what you're looking for. But so it's important to really look at the rash and get it and feel for how it, what it looks like, and to be able to describe it. So now we're going to talk about how to differentiate the rashes and what to look for. So like I said, the skin can only do so many different things, but it's really the pattern and the timing of when things come up. So here are your most common drug eruptions, and so it's really the timing of when the medication was given and when the rash occurred. So we're going to talk about each of these, but if it's quick, if it's within hours, it's usually more of urticaria. If it's days, there's something called AGEP, or acute generalized erythematous pustulosis. If it's more about a week to 3 weeks later, it's more of your SJSs, Stevens-Johnson syndrome, morbilliform eruption, exfoliative or erythroderma. And then if it's a longer term of about 3 to 4 weeks, it's more of DRESS, which we'll talk about what that stands for. So the first case is a 35-year-old male who presents with a pruritic rash after starting amoxicillin 2 days ago. It seems to move around, and he's never had amoxicillin before. So this is what you get. So as you can tell, they're erythematous wheals. A lot of times they have central clearing in the center. It moves around. So you look at one spot, and he's like, well, the next day that spot's not there, and it just seems to kind of move around the body. So this is urticaria. So urticaria is quick. So it appears minutes to days after taking the medication. The causes are typically antibiotics, can be more like local anesthetics or radiocontrast media. And this is actually my daughter after getting amoxicillin. So this rash was on her thigh. 4 to 6 hours later, it moved down to her shin, and then it kind of went to her abdomen, and it just spreads out. And so that's the most important thing with urticaria. It's not fixed, so it shouldn't be there more than 24 hours. So if you actually circle one of those lesions, it shouldn't be there. It should at least move in 24 hours. If it stays there after 24 hours, it's probably not urticaria, or it's more like urticarial vasculitis, which it can be caused by medications as well. I'm not going to really talk about the difference between those two today, because that's kind of a whole nother lecture. But quick things about urticaria is it's itchy, it moves. And so to differentiate urticarial vasculitis, that's usually more fixed, and it hurts, and it a lot of times leaves bruises and things like that. So how do you treat urticaria? So the first thing you want to do is get them on a second-generation H1 blocker. So for the skin, typically Zyrtec and Allegro work better than Claritin, so I typically start with that. And then I titrate that up, typically going to twice a day, and you can go up to 4 times the dose with your Allegro or Zyrtec. Then I typically add an H2 blocker, so that's your cimetidine and ranitidine. And then you throw in your Benadryl, Atarax, or your sedating H1 blockers for breakthrough. Steroids, they do okay. They don't typically work as well as we think they would. So sometimes I give them, a lot of times I don't, and just really do more of the antihistamine route. And then a lot of times we'll use more of the topical steroids for it. So that's more urticaria. So case 2 is a 22-year-old who started doxycycline a few days ago for acne, and then he started to develop this rash, which is very pruritic. So you're wondering, oh, did he have like a big flare of acne? But when you look at this, there's pustules, but they're non-follicular, so they're not around the hair follicles. They're coalescing into this lakes of pus, which you can see on his arm. Do I have a pointer? Oh, here we go. Let's see. Does this work? Okay. No, it's not working. Okay. And it coalesces this lake pus on the arm, and then you can see it's actually kind of exfoliating a little bit more down on his chest there. So this is AGEP, which is acute generalized exanthematous pustulosis. So here's actually my patient. She has hidradenitis suppurativa, so that's what's going on in her axilla. But if you look on her arm, she has these tiny little pustules kind of going down her chest and down her arm as well. So she was gave her Bactrim for the HS, and then she developed this other rash kind of all over her. Again, it's very pruritic, and it's most often caused by antibiotics, your tetracyclines as well, and then calcium channel blockers. Again, it's a quicker eruption, so it usually starts within 2 days of giving the medicine. Topical steroids are typically the treatment for it. So like I said, it's usually always medicine with AGEP, although it can be, it can occur in things like spider bites and things like that. I actually just had a patient this week who had a spider bite on her abdomen and then all of a sudden broke out in more of an AGEP rash all across her body. So it can be also medicine. So you obviously need to get a good history of what's going on with your patient. So like I said, the treatment is topical steroids, but just a quick side note, what topical steroids do you give? So this is just a quick little chart of if you just have your few steroids that you use, and you can, if you know where to use them, then it's not as confusing because there's a lot of steroids out there. These are all cheap, so most insurances will cover all these. So for your class 1, your super potent is clobetasol, although recently insurance is not liking to cover that one. They go between that and, 1 month they will, 1 month they won't. So you want to have a backup plan. Typically mine's what's called, which is Diproline ointment, but it's kind of a side note. But so clobetasol is really strong. You don't want to ever use it on the face, armpit, or groin. And it's going to be really for those thick areas of the skin that just won't clear up. So hands and feet it's good for, or really thick skin, like a psoriasis type rash or something like that. Your mid-strength is your triamcinolone. So for AGEP, that's what I would give is triamcinolone cream. So you want a mid-potency, and you don't want to use it on your face, armpit, or groin area, but it can be used really anywhere else on the body. And then your mild classes, you can is aclamethasone, or you can even just give hydrocortisone 2.5% cream. Now, not 1%. So people will tell you they used over-the-counter 1% hydrocortisone, and that's basically like using lotion. So if they said, well, I use steroids and it's not working, you just tell them that what you're giving is a lot stronger. So remember a couple other things with topical steroids. Ointments are stronger than creams, and they're just absorbed better. So if you really have somebody who's really broken out, give them an ointment, and then you need to give enough. So a lot of times they'll come for hospital consults and they'll have a itty bitty 15-gram tube and they have a rash all over their body, and that's just not going to work. So a 30-gram covers a whole entire adult body. So you want to make sure you give enough for it. So granted, they're not going to be doing it on their face, armpit, or groin, but you want to have enough that they can use it. And if you remember, when you treat scabies, if you remember, it's 30 grams for your application of scabies, and that's because you do from your neck all the way down to your feet, and you repeat it 7 days, so you give them 60 grams total. So that's just because it takes 30 grams for each session, each time. So I typically write, if I have somebody with a rash from head to toe, I typically write for a jar at bedside, or I send them home with that. People actually don't use steroids as much as you think. They are pretty hesitant, and they've done a lot of studies where they show that, like, they do cap monitorings of different jars and things like that, and people don't typically use them as much. So a lot of people have steroid phobia. So you do want to tell your patients, you do have to be careful with it, but when you are broken out, if it's just like a week or so, feel free to use this topical steroids. Another quick tips for somebody who has a severe drug eruption and they're just covered head to toe are what are called wet wraps. I do these all the time, and it shows a kid, but I do them in adults constantly. So basically they take a bath, they take a pair of tight pajamas, and they wet those while they're taking a bath. Afterwards, they get out, they just lightly pat dry. They don't dry off completely, and then they put on their triamcinolone ointment. They can put it on from neck, all the way to feet, and then they take those damp pajamas, put them on, and put dry ones over it, and they sit in it for about 2 hours. You will turn somebody around very quickly with this. I recently had a consult of a patient in the ICU who had erythrodermic psoriasis and a drug eruption on top. She was given, they were doing wet wraps in the hospital, and in like 3 days she's completely different. So it's something you want to remember. In the hospital, you just have to tell the nurses how to do it. This is actually my daughter showing an example of wet wrap. She has bad eczema, so the pajamas on the left are wet, and then she just puts a little dry thing over it, and it's very soothing and helps a lot. So that's just a side note of how to treat the drug eruptions. So let's move on to case 3. So it's a 30-year-old who recently had an earache, who was started on Augmentin and developed this rash. So on the hands, there's targetoid lesions. So you can tell there's 3 different colors within it, which is important to determine from urticaria, which is typically has the central, in the center is typically clear, or it's lighter. So this has the 3 different colors. It's fixed. So we talked about urticaria that moves around. So this rash is fixed. And typically they're febrile and things like that. This is actually my patient who had this on her hands. Hers are a little bit more vesicular or bullous, but again, this is, so with this rash, this person had Augmentin, but you also want to ask them if they've had a cold sore, because a lot of times people get sick, they're given antibiotics, and the stress and everything of having the illness will develop a cold sore, because the most common cause a lot of times of this, which is erythema multiforme, is more viral or cold sores, not actually drug related. We'll talk about EM major in a second, which is usually more associated with drugs, but erythema multiforme minor, or the simplest form where you have these really nice targets, you are febrile, they're usually a little bit more itchy. It's usually more viral related versus drugs. So I threw that in there just because a lot of times people get confused between those two. And EM typically doesn't go on to form Stevens-Johnson's TN, which we'll talk about in a second. So treatment for this, again, is the topical steroids that we talked about. And then you always want to, if you see this, you do want to ask about cold sores, because acyclovir can help as well. So then this next case is what most people probably were starting to think about with the last one. So it's an 8-year-old girl who was started on Bactrim only 5 days ago for MRSA, who now has a high fever and this rash. So as you can tell, mucous membranes are involved. Her eyes are actually fine. They're clear. She doesn't have any ocular involvement right now. She says it kind of hurts a little bit to go to the bathroom. It just feels sore. And then you can tell there's these bulla that are on her face and chest. And if you touch the one like on the chest, it's very flaccid. This is another patient on the hands. So this patient I'm going to talk about, this is obviously Stevens-Johnson syndrome. I said in the beginning that it typically is about 1 to 3 weeks after you get your medication. This patient only got it 5 days after. This is because she was on Bactrim before. So you got to remember, yes, you have your timing, but having it a past exposure will change when you can actually develop this rash. So she got it 5 days after because she's had MRSA in the past. She's got given Bactrim. Now she was given Bactrim the second time, and she developed it quicker. So Stevens-Johnson syndrome or toxic toxic epidermal necrolysis, sorry, I can talk, or SJS-CEN, is what we're going to talk about next. So the difference in this is the skin, the main thing you're going to get from your patients is the skin hurts. So a lot of times when the skin hurts, it's a bad sign. Most of the ones that are more not severe, the skin is really itchy, and the patient is bothered by it. But this one, it hurts. It's very dusky color, and it just looks like the skin is dying. And then the skin does slough off, and it's a deep slough. So it's at the D junction. So the whole epidermis is sliding off from the dermis. So it's not your superficial exfoliation, which is like what you get more with sunburns and things like that, or staph scalded skin, where you just get the superficial sloughing there. So you have the Nikolsky sign, and that's when you rub the skin, it just separates from each other, it just slides. And you can tell, again, it's a deeper sloughing there. So just a summary, I know this is a busy slide, but this goes through the EM minor that I was talking about with viral infections. And you can see up at the corner over there, it does talk about viral infections. And then you have your EM majors and then your SJS. And the main things between them is the mucosal involvement and systemic symptoms. So, and typically the other ones, EM major and SJSs, are usually always caused by drugs, which is in your side corner. Now, there's one thing I want to mention about another virus that can cause a very Stevens-Johnson's looking rash, and that's mycoplasma. So you want to, if you do have somebody with Stevens-Johnson syndrome, you do want to make sure, if you can't figure out a drug that typically causes it, mycoplasma is one that can cause Stevens-Johnson syndrome. Typically, it's a lot of mucosal involvement, and there's minimal skin involvement, but you do want to look for that. So you want to get a PCR of mycoplasma. Typically, it's a little bit more in kids, but adults can get it as well, but it's more ped side. So what's your definition? So why is there SJS and TEN? And it's all just based on how much body surface area is involved. So it's all a spectrum. So there's really no difference between SJS and TEN. It's just how much of the skin is involved. So, and that leads to their prognosis. And you just determine that just like how you do with burns, and just determine how much of the body is involved, body surface. So how does it present? Like I said, it's a rash that appears about 1 to 3 weeks after exposure, days after second exposure, and it's more of a fever. They get fever and flu-like symptoms about a couple days before either the mouth is involved or the skin becomes involved. And it's, again, very painful, so that's your big clue you want to ask patients. Typically, if it itches, it's not going to be Stevens-Johnson's again. And you need to have 2 mucous membranes involved. Here's your medications that typically cause SJS. So it's a lot of your anti-seizure medicines, your antivirals, antibiotics. Allopurinol is a big one, and Bactrim, which we talked about, which is your antibiotics, is a big one. Now, they recently did a study, and they looked at, this one came out just recently, 2017, where they looked at different regions and what was the most common. And so I just wanted to throw this in there. Another big one is actually Tylenol or acetaminophen. So you want to make sure you get the over-the-counter histories as well. So in Indonesia, they did a big study, and they found that most of theirs was caused from Tylenol. So, and then it was antibiotics and things like that. And in Japan, it's more of the anti-seizures. Europe was more allopurinol. France, antibiotics. And this all really comes down to, we found that there's a lot of genetics involved with Stevens-Johnson syndrome. So there's a lot of these HLA subtypes that in different populations you're more likely to get Stevens-Johnson syndrome from getting these certain medications. So some places and regions are testing it to see if you can even get the medicine. So there's a lot of genetics involved, and so that's why the different areas are more common with different medications. So you just want to remember, you see this person with Stevens-Johnson syndrome, you just have to think about the other things causing vesicular bullous rashes, and so just keep the other ones in your differential as well. So so now you have this patient with Stevens-Johnson syndrome, what do you do? So the main thing, obviously, is to get rid of the medicine. they can, as soon as they stop it, they're going to start hopefully to get better. But the most important thing is stop the medicine. Main thing is just supportive care. They're losing a lot of fluid, so you need to make sure they're getting, enough hydration, enough calorie count. They're getting just intense care. So usually ICU or burn unit, they need a lot of nursing care. And then there's some treatments, which we'll talk about in a second, that plus or minus can help Stevens-Johnson syndrome. So again, the most important thing with Stevens-Johnson syndrome is how sick are they. And there's this criteria where you can figure out how sick your patient is when they come in, and then it gives them your mortality rate. And they've actually found that, so with treatments with Stevens-Johnson syndrome are very controversial. Some studies show certain things work, some studies show certain things don't work. And they've basically found that it's really based on this number, the score 10 number. So if the patient had a low number, they usually did better. If they had a high number, they usually did not so well, no matter which medicine or treatment was given. So a new recent study, just again in June of this year, they correlated all the data from all the different studies, and they found that there's no real treatment that helps SJS. So the main thing they emphasized in this article was, again, stop the medicine and do supportive care. Now, most academic centers, and where I trained, we always would give IVIG, 2 grams per kilogram over 3 days. Again, studies show, yes, sometimes it works, sometimes it doesn't. Newer studies are showing that maybe cyclosporin will help, or TNF-alpha inhibitors. And that's, again, because Stevens-Johnson is a immune-mediated complex. It attacks your fast ligand receptors, which activates the TNF-alpha chain. So that's why they think the TNF-alpha inhibitors work. But again, there's not enough data out there if it works or not. So if you have a patient with it, you're really going to be doing, especially if you work in an area where you don't have derm or things like that to come in, as long as you're doing stopping the medicine, supportive care, you're doing the right thing for your patient, at least at this point. So case 5, a 45-year-old who has redness from head to toe, recently started Bactrim. He's very itchy and no fever. So this is what he looks like. He's head to toe pretty much red. And he's peeling at certain areas. So this is more of your exfoliative dermatitis or erythroderma from medications. It's widespread erythema. 80% of your body surface area is involved. Again, it itches. There's no pain. There's no bulla or anything like that. It's usually caused from medications, although you have to, again, think about underlying other things like did they have a history of eczema or psoriasis and things like that. Treatment is mainly, again, the topical steroids. Wet wraps work really well on this when they're head to toe red. And then, again, plus or minus steroids. And then a lot of times these patients, they can be febrile because, again, the body surface area is so involved, they're losing, again, a lot of fluids. They can be tachycardic, things like that. So a lot of times they are admitted for just supportive care as well. And then case 6 is a 40-year-old man who presents with this rash after 2 weeks after starting allopurinol. He, again, is very itchy, no fever, and he looks like this. So this is the rash that, so as you can tell, there's a lot of papules and macules are coalescing together. This is what dermatology usually, it's a morbilliform rash. That's how we say it. A lot of people will call it macular papular, but it's more of what's called a morbilliform eruption, and that distribution is just called morbilliform. But it's 75% of drug, or 75% of these rashes are caused from drugs. So again, it starts 7 to 14 days after a medicine is given. It starts on the trunk, it spreads out to the hands, and it becomes progressively more confluent. It typically does not go on to become Stevens-Johnson syndrome, but you do want to tell them, if you start to get blisters, you get mucosal involvement, you need to come back to the hospital. You want to tell your patients it takes 3 weeks to get better. So you're going to have this for 3 weeks, and then you're going to peel like a snake when it goes away. So if you don't tell people that they're going to peel like a sunburn or a snake, they're going to start to freak out because you've told them if skin starts to peel, they could be giving Stevens-Johnson syndrome. So you want to tell them they're going to have a superficial kind of peeling afterwards, and that's normal and that's okay. This they also think is more of a delayed hypersensitivity reaction. Again, it may be an early stage of other reactions like Stevens-Johnson syndrome or another one which we're going to talk about in a second. It's more common in patients with an altered immunity, so people with HIV or patients with like mono or some other type illness. So if you remember, you have somebody with mono, you give them ampicillin, they get this rash, and that's because of this type reaction. So usually not allergic to ampicillin, it's just that rash that they get afterwards. So again, morbilliform eruptions are itchy. They can have a low-grade fever, but it doesn't hurt. It gets worse before it gets better. Again, it takes 3 weeks to go away, feels like a snake. And basically, it's just supportive care again, topical steroids, sometimes PO. As you can tell with a lot of drug rashes, I give more topical steroids than I give PO, and that's just because it seems to work better. And the PO steroids don't seem to do as well with the skin, unless there's one reaction which we're going to talk about. And again, too, if you're kind of going on to Stevens-Johnson syndrome or things like that, steroids are, again, very controversial in the care. They found that it maybe made the symptoms worse in the end or the outcome worse in the end. So if you stick with topical steroids, you're going to be right either way. So this is another case. This is a 50-year-old woman who presents with fever, diffuse rash, facial swelling, and she's been on phenytoin for 4 weeks. This is her. So you also feel her neck. She has lymphadenopathy, and she looks like that morbilliform eruption that I just talked about from head to toe. But her face is just a little bit more swollen, and she's febrile. So this is your DRESS syndrome, or drug hypersensitivity syndrome. And DRESS stands for drug reaction with eosinophilia and systemic symptoms. Although the times you actually have eosinophilia is probably a lot lower than what the name says. So it's basically a morbilliform eruption, you have fever and facial swelling, and again, lymphadenopathy is big with it as well. These people have internal organ involvement, so you do have to check labs. So you want to check CBC. Again, they can have elevated eosinophils. Most of the time, though, they have more of like atypical lymphocytes. You want to check the liver, because 70 to 90% of the time they'll have liver involvement. So LFTs, check those. You can have myocarditis, pericarditis, so more of a chest pains. And then the other thing you want to look at is the thyroid, because a few months after having DRESS, they can start to develop hypothyroid. So you want to make sure you check those labs afterwards. Again, this is more of your delayed T-cell mediated reaction. These people actually have a genetic predisposition just like SJS does, and they think it has to do with the same HLA subtypes that we talked about before. And also viral reactions or viral infections can play a role in this too. They think it's also a reactivation of herpes, HHV6 or EBV may play a role in it. So what medicines commonly cause DRESS syndrome? So these are your seizure medicines, your aromatic ones. So these all will cross-react. So if this patient comes in with a phenytoin reaction, they can't be put on the same type class of medicine. That you have to completely change the class, otherwise they will have DRESS again. So you have to go more to your Keppra or valproic acid medications. So, and then the other big one again is Bactrim, or the sulfonamides. Here's the other drugs implicated. And if I just put this up here to see a lot of these are the same as what happened with Stevens-Johnson syndrome. So you have your main kind of culprit medicines that cause the different drug eruptions. So DRESS is a longer reaction. It takes 3 weeks usually to be on the medication before you start to develop DRESS. So you want to get a good drug history and see if what's, even medicines that it can be up to 8 weeks too. So you want to figure out what the patient has recently started or within the last several months. This one you do want to give steroids to, and you have to give at least a 3-week taper. If you just give a short kind of Medro dose pack or something like that, the rash is going to come right back in with a vengeance. So you want to do a 3-week taper. I typically do 60-40-20 over 7 days of each, all in the morning, and that typically gets them over this reaction. And that's another side note with skin. If you're going to give a steroid taper, typically you do want to give about a 3 3 weeks worth. That goes for poison ivy, goes for this. So it's just because the skin will rebound pretty quickly if it's given a shorter taper. So, and then I also do give the topical steroids as well, and wet wraps and things like that. Okay, so those are your main drug eruptions. I went over them kind of quickly, but and so the most important thing is timing, and when the which medicines they were given, and then again, a lot of it is supportive care. So I have to throw this last one in here because it is a drug rash, but it's one of my favorite kind of topics with dermatology. So this is an 18-year-old girl who presents with this rash. This is actually my patient I saw in the ICU when I was a resident. Her ear is necrotic on both legs and arms. She looks like that. So you get a history that she, I talked to her for a long time and we weren't getting much of a history, but then she finally told us that she used to do IV drugs, and now she started to do it again, and she's been using cocaine since this started because she's been having a lot of pain, obviously from these lesions. So does anybody know what this is? It's kind of been I don't know if it's been in the main literature, but in the derm literature it's been crazy. So some people may think, more of like a vasculitis, a Wegener's, that type kind of reaction. But this is actually levamisole-induced necrosis syndrome or levamisole-induced purpura. So why is that? That's because, and I'll talk about it one second. I just want to show you one other picture. Again, it just attacks the earlobes, a lot of times the nasal tips, the cheeks, and then you get this retiform purpura. And that's because levamisole is now, so it's a veterinary medicine. It used to be used for nephrotic syndrome in the U.S., but it got pulled off the market because people started developing this type of purpura. But it's a thing that's actually used to cut cocaine in Colombia. So typically when drugs are brought into the U.S., they're cut on the street, but this one is actually cut in Colombia. So, and it actually has the right look, taste, and melting point to go unnoticed by cocaine users. So it adds bulk to the cocaine, makes it cheaper, but nobody can tell that it's there. And it also affects the acetylcholine receptors, and so it boosts your heart rate. So actually, cocaine users think they're getting more of a high with it, even though it's not pure cocaine. So in the U.S. now, 82% of the U.S. cocaine that's brought in is cut with levamisole, and that's up from 30% in 2011. So if you look this up, there's just a lot of cases with this, and it causes a lot of, they've actually developed, I think I just read recently, like a postage stamp where you can put, I don't know if it's in the U.S. because it was kind of vague on the website, but you can put it on there and they will tell you if there's levamisole in the cocaine. It's a way to kind of, I think it's a little bit more for hospitals. They're trying to develop some way for them to kind of tell what's going on. But what does levamisole do? It causes agranulocytosis, neutropenia, and then it causes this purpura. Patients will actually have a positive ANCA or ANA, so they do look like a Wegener's or more of a vasculitis. So typically the lesions will clear once you 2 to 3 weeks after stopping cocaine. Now the patient I showed you, she did a lot better, but she had to have a lot of grafts done because of, the area just was dead. So she had to have skin grafts and things like that. But her labs, she had a positive ANA and ANCA, and hers went back to normal after she stopped the cocaine. And the levamisole got out of her system. Now, it's hard to test because it has a very short half-life, so you can't actually test to see if there's levamisole in the system. I saw another case one time too, and so you just have to get that history of drug use, which sometimes is very difficult. So, sorry, that was a side note because I saw that case, and then I wrote a chapter for drugs of abuse in dermatology. So it's kind of drugs, but it also shows you some of the purpuric lesions that can happen with medications. You have your Coumadin-induced necrosis and things like that. So that's another one of those primary lesions I was talking about. That's more of an ecchymosis or purpura. So any questions? I probably...
Dr. Hennings, thank you for that
Yeah.
talk. I had a question as an infectious disease doctor.
Yeah.
The drug eruptions related specifically to beta-lactams.
Mm-hmm.
Which ones you would counsel your patient to list themselves as penicillin allergic?
Oh, which of the reactions would you have them do? Typically, I'd say, I mean, if they had most of them, I would list them as allergic. You're saying like if they had like a hive reaction, would you put the allergy for beta-lactams down? Typically, I will do that. Although the problem is, again, if a lot of times, especially morbilliform eruption, it happens, after an antibiotic is given. But again, viral reactions can give you that same morbilliform eruption. So my daughter, who I showed the amoxicillin, she had like kind of a ear infection. It was lasting a long time, and then she got amoxicillin and then developed the hives. So I have her right now as penicillin allergic, but although I'm kind of skeptical because it may have just been from the viral rash. So I always tell them that if they need it or something that they're going to have to get, then to go to allergy and they can actually do the prick test or actually test them if they're allergic. So I caution them that they may not truly be allergic, especially if it's more of like a morbilliform eruption. But if they have any like swelling or signs of anaphylaxis, then then definitely I'd put it on there. Mm-hmm.
Any other questions? Thank you very much.
Thanks. You're welcome. No, I
It can be overwhelming.
know it's hard. Sometimes I have a hard time.